Hello, and welcome to this webinar, Respiratory Season and Update. I'm George Hammond, your host for today. We have a fantastic presentation in store for you featuring our esteemed speaker, Dr. Rodney Rohde. Dr. Rohde will be sharing his expertise on the respiratory season landscape and how we can all best prepare for the upcoming season. Before we dive into the presentation, let me introduce Rodney. So Dr. Rohde is a Regents Professor at Texas State University System and Distinguished Professor and Chair for the Medical Laboratory Science Program in the College of Health Professions at Texas State University. Dr. Rohde has published over 100 research articles and abstracts, 2 books, and is highly sought keynote presenter with over 100 international, national, and state conference presentations. A very warm welcome to you, Dr. Rohde. Following the presentation, we'll have a Q&A session where you will be able to ask any questions you may have for Dr. Rohde to gain further insights. Please feel free to submit your questions at any time during the presentation. If you encounter any technical issues, the team will assist you. And now, without any further ado, I'm delighted to hand over to Dr. Rohde to share his insights and begin his presentation.
Thank you so much, George, for that warm welcome. It is absolutely an honor and a pleasure to join you today. And I'm really excited to talk to you about the upcoming respiratory season. I have been doing this in the past few years, as we all know, with respect to the different things circulating in the respiratory agent world. So let's get started. And you saw my introduction, but here is just a quick slide of some information about me if you are interested in connecting later or following me on various platforms. So just a quick overview. As we all know, we've had kind of an interesting, really 4 or 5 years now when it comes to the respiratory season. And in my historical career journey, all the way back about 3 decades, I've been working in the world of public health and zoonotic infection. I worked for the Department of Health in Texas. I did some time with CDC, and now I'm at Texas State. So I have lived through a variety of these types of respiratory agent outbreaks, as well as other zoonotic outbreaks like West Nile virus, things like that. So what was kind of interesting in the past couple of years is we did see this kind of tripledemic, right? Flu, SARS, and RSV. That's changed a little bit as we've kind of evolved over the last year or so. And so what I'm going to be talking about today is really those 3 agents with various characteristics, including the importance of laboratory validation, especially for those 3, and then also talking a little bit about, as best as we can, the upcoming 2024-25 landscape. There have been some new game changers with respect to RSV, with respect to some testing, and the current bird flu outbreak that's kind of popped up in the US and elsewhere. These are the learning objectives that each participant should be able to handle after this talk. Just basic background of the 3 agents, risk factors, different patient populations, upcoming season. Hopefully we can get that across in both the US and Europe for you. And then again, a little bit more about testing where it is pertinent. So I always like to start off, I'm going to start with influenza, and this comes from actually a book, or a report rather, from the National Academy of Sciences. I like to share this with the audiences, especially audiences that are not in the scientific world. And just one little quote in there that's always interesting to me about the perfect storm, right? So unlike a major climatic event where various meteorological forces converge to produce a tempest, the microbial perfect storm will not subside. And there is no storm like influenza. And it's certainly a pathogen that we all respect and at times are wary of in their ability to be diabolical in their ability to mutate. I also like to remind people that the only thing certain about influenza viruses is that nothing is certain. And so there's a high level of uncertainty. The predictions and the best education around agents circulating, different variants, is always a best guess in some cases, but an educated guess. So we'll kind of talk about that today and why that is true. So the virus itself, influenza, is an RNA virus. And I highlight that on purpose because RNA viruses are notorious, and I often say diabolical, in their ability to mutate annually. RNA viruses, much like flu and RSV and SARS, are also very smart and mischievous in this aspect. And they also, especially flu and SARS, can live as a zoonotic agent. That means they have a reservoir in the animal population, which makes it difficult to totally eliminate. They always have kind of a stealth hiding place out there in that particular world. They have long been an inhabitant of swine, fowl, and humans, which continue to allow for something we call antigenic drift, which are little tiny changes in the genome, and then shift, which are major changes. And that's typically going to be one of those problematic changes that we may not be prepared for, both in a testing situation, but also in a vaccination situation. It's very contagious. It can cause severe illness, including hospitalization and death. We'll talk about some of those statistics soon. And really older people, young people, this is kind of true of most agents, right, that are respiratory. People with high risk conditions can often have, serious complications from things like influenza. When you look at the types of influenza virus, there's really a set number. Type A and B are the primary circulating viruses that we'll talk about soon. Type C is not really clinically relevant to humans, and D is typically only found in pigs and cattle. The A and B viruses that you routinely spread in people are responsible for most of the seasonal flu epidemics each year, and we often refer to type A as the pandemic strains that we deal with. So here's just a picture. This is a picture straight from the Centers for Disease Control in the public domain. Let me back up for that. I'm sorry about that. And you can see here that they're classified by these subtypes that I talked about. So the H and the N, if you look at that quickly, those are found on the surface of the virus. These red and blue lollipops, we often refer to them as lollipops, and they are often sometimes referred to as spike or flags or markers that are found on the surfaces of cells. And what's notorious about flu is that these 18 different subtypes and 11 different NA subtypes, so you have a hemagglutinin, which is H, and the neuraminidase, which is the N, they can recombine and change based on genetic changes and evolution and evolving of the virus. And thus you get these subtypes that you see popping up in news stories like H1N1, H3N2, H5N1, and you can kind of see those in the news often. That'll pop up in what's happening around the world with respect to viruses. In the center here, you see this ribonucleoprotein, which is the RNA virus associated with proteins. So a very simple creature. Viruses are very simple, but they are very notorious for being just a tad a bit ahead of our immunity and other ability to stay on top of it. A little bit of background on understanding the naming of flu viruses. I like to do this just to remind the public. Sometimes you'll see this type of nomenclature, and the first letter A is the virus type, so A or B. Sydney is where the virus is typically isolated, so that's a geographical location. Then you'll have a strain number, the year isolated, and then what most people see, in all honesty, is the virus subtype. So typically what you see in the press or even in certain types of websites and other publications is the virus type, like A, H3N2. And so that's often where you see immediately what's circulating. And just for some quick nomenclature that you might see in the press right now, or occasionally if you're looking at the WHO or the CDC or perhaps public press articles, H1N1, all of these are A types, is typically seen in swine. H3N2 is typically seen in swine as well. And then H5N1, which is the one we're kind of watching in the US right now, is typically a bird strain. But note that all of these can circulate in humans. It just kind of depends on their ability to shift or transition into the human host. And sometimes they'll circulate back and forth between avian, swine, human, and so that can happen sometimes. Some of the history and background. Again, most of the time when you're thinking person to person, this is direct transmission, usually respiratory droplets, although touching your face and your nose with your hand can also transmit that. That is via high touch surfaces or fomites. So there is a role that surfaces can play in the transmission of many agents. People who are infected with this in particular virus and many others are most contagious early on in the first 3 to 4 days after you see symptoms or their illness begin. A lot of healthy adults may be able to infect others really beginning in the first day before symptoms even develop, in up to 5 to 7 days. So this is just kind of a range and kind of an understanding of when you can be contagious. I often will tell people, because you'll hear in the press or maybe even from your primary care physician, once fever subsides for 24 hours, you can safely go back to work or interact with people. I'm a little more conservative. I think that even though your fever has broken and you may be feeling better, you potentially still could be shedding virus at low numbers, a low titer, and you potentially could shed virus to the public. I especially tell people to think about that if they are interacting with their elderly parents, or perhaps they're in healthcare and they're around immunocompromised patients and so forth. So you want to be kind of cognizant and understanding of the people you're interacting with. Even if you think you are done with the infection, you may still be shedding it. And so sometimes you can also pass this on to someone else before you even know you were sick, as well as while you were sick. And then, as we learned during the pandemic, at least the public learned, you can have asymptomatic situations where perhaps you have a very low clinical infection and you may not even know you're ill, but you could be shedding virus. And so that's the most difficult situation because you may not realize you're sick. Here are the next few slides are kind of around epidemiology, and these are going to be mostly from the Centers for Disease Control. And so this is a slide just kind of giving you the range of annual burden of flu in the United States, really from about 2010 up through 2023, so last flu season. And you can see here this range, it kind of jumps depending on, because we're looking at a broad time of space here, but about 4,900 to 51,000 deaths, over 100,000 and up to 700,000 hospitalizations, depending on the year, and then lots of illness, up to 41 million being affected by this particular virus. And this slide shows you the breakdown of those years, just to give you a little bit more kind of look at that. And you can see, if you look across here, I'm just going to point out 2017 and 18, and really our current year, the 23 year, have both been pretty high across the board, 19 and 20 as well. What's interesting, this 2021, 22, you might remember this effect, we think, that was because of COVID. We had a lot of contact precautions. We had people being isolated and quarantined. There was quite a bit of mask utilization, physical distancing, people being really, really careful right after that 2020 outbreak of COVID-19. And so we believe that really low season had to do with really our behavior during that time. And just another kind of look at this information, looking at each flu season. So you can see here again, the one I highlighted earlier, this kind of yellowish graph, that's the 2017-18. And then the red is the 23-24 last season. So those two seasons kind of stand out as a little higher incidence of both rates per 100,000 in the population. That's a typical stat that is given in public health and other publications. And certainly those years stood out with higher illness, higher death, higher hospitalization than some of these other years. Some quick snapshots for trend indicators. So just a quick mention, when you see these arrows in some of the slides coming up, a red up means things are increasing. This is typically over the last week or so, or they're decreasing if it's green and down, or they're kind of maintaining balance, they're stable. This is through July 6th of 2024. This is about the most current data I could grab. They put this out, the CDC puts out this information. This is called Flu View. This is a weekly surveillance report from the Influenza Division. I highly recommend you bookmark this or check it out if you're interested in following the trends throughout the season and the year. And you can see right now in the clinical labs, we're right at a 1% kind of stable positivity rate for this week. The primary strains that are circulating are H1N1, H3N2, and then we still have some B viruses. Those are all co-circulating. I'll show you a little bit about the characterization later. There's about a 1.4% overall respiratory illness going on this past week. Really low weekly hospitalization rate. That's good. This is typical in the summer. This is mostly a seasonal problem in the fall and early winter. And then mortality is pretty stable. And you can see last week there were 2 deaths reported. And we'll look at some mortality here in a minute. Again, reminding you right now, H1N1, H3N2 are the primary things that are showing up in diagnostic testing, but we are watching this bird flu incidents happen right now in the US. This is last season, so October 1st, 2023 through really midsummer right now. And you can see, again, they're kind of giving you this snapshot. So somewhere between 35 to 65 million illnesses. So looking at just this past season, almost 30 million medical visits, close to 800,000 hospitalizations. Again, this is a high range. It kind of depends on the data you're looking at. And then we believe up to at least 72,000 deaths, depending on the data. So again, every year there are issues around influenza mortality and morbidity. Some years are worse than others. It kind of depends on our predictive modeling for which vaccines to use and our protection levels, and then the public's acceptance of being vaccinated and also following those other types of precautions around, staying home when you're sick and trying not to help spread infection, whether it's flu or something else. This is a geographical map of the United States. You can see this is through the week of July 6th, 2024. And really, we call these heat maps. The hotter or the higher positivity level, the activity you'll see all the way up into the purple ranges. So as you can see right now, or about a week ago, we are at pretty minimal to low types of influenza activity in the United States, at least. Sometimes on other parts of the world, like in different areas, like even Australia and places like that, you might see a higher incidence at this time because they're in the middle of their kind of seasonality of the flu. This is kind of a busy slide, but I thought it was important to kind of show you some of these data. So remember we talked about the types of specimens circulating. The slide on the left is, as you can see, if you look right here where my arrow is clinical laboratories, so actual hospital types of laboratories. And then on the right, you're looking at public health laboratories. And again, this is up through July 6th. And they kind of mimic each other, but it's just to show you we do get specimens from both hospital labs and public health labs that contribute to the data. And if you look at this left side on clinical labs, you can see that primarily almost 93% of the specimens that have been typed are of the A variety. The remaining 7% is influenza B. And then over here, public health labs are more involved in subtyping. And so you can see that 93% of A, it's really broken down into roughly H1N1 is about 22%, and H3N2 is about 73% or so. So that's kind of how they break out. And then B, which are typically not your pandemic strains, but they are co-circulating, is mostly, you see here in this Victoria lineage. Now, the reason I show you this a little bit is because in a moment, I'm going to show you the upcoming vaccine for 2024-25, and you'll note that this is how we predict really around the world, but talking about the US here, which strains to include in the vaccine for the upcoming season. So we're always looking at what's happening, in our surveillance within a public health stance to kind of figure out which vaccines we're going to utilize. Again, just a mention that CDC antigenically characterizes influenza viruses by a test known as the hemagglutination inhibition. They also use molecular testing at times. And again, you can see H1N1, H3N2, and B Victoria are the primary viruses here that we see on this slide. It's a little busy, But again, sometimes they'll even do subtyping. As you can see, that's what 2A and 2A.1 is. This gets more into the epidemiology of what's out there, remembering that the vaccine typically covers those subclades as well. Just another quick look at that COVID-19 effect. I thought this was kind of a nice slide to share. These are all CDC slides. So again, you can see the seasons here. 19 and 20, 20 and 21, 21, 22. This is last year. I'm sorry, this is 22, 23, 2020, 23, 24 was last year. And here that COVID effect really swallowed up all that isolation, quarantining, physical distancing, we think really pushed down flu incidence in those 2 years. And now they're back up to kind of normal levels the last couple of years. This is looking at influenza-associated hospitalization rates among pediatric populations. So kind of a quick look at young children by season. Again, this is from 2012 to 2023. And you can see that pediatric hospitalization kind of bounces around. The different colored lines kind of can break out the years. If you're looking at that, what's really noticeable in this graph, in this type of presentation of data, is that last year we had this really early and large peak last season in this particular population. So young children really showed up pretty quickly, really around October, mid-October, and then they peaked right around Thanksgiving in early December in the US, and then it came back down as we moved into January and February. So that was like a shift of almost 2 months in kind of seeing this at a higher level in this population. This may have been due to that population was very young or even infantile during COVID, and perhaps they were never exposed to influenza strains or maybe not vaccinated, and so they really peaked early in this past year. Kind of an interesting look at the data. And then this, again, staying with flu here, shows you the seasons, right? And again, you see the COVID effect in the 2020 through 22 years. And then you'll see the last 2 years, the number of deaths. Again, this is pediatric deaths, not overall deaths in the US. So you see we had pretty high numbers at 185 and 186. We're at 186 right now, as current data shows, for pediatric deaths over the past season or two. During COVID, again, you see those low numbers of deaths. So, according to the CDC and those who keep track of this information, last season's flu vaccine's effectiveness kind of varies by age group. 6 months to 17 years old, it looks like it was around 55% or so. Older adults, 18 and older, a little less protective, 33 to 49%. Again, looking at different data subcategories, this kind of changes, but it's roughly in that area. Influenza A overall, approached 60% effectivity in children, about 45% in adults. And then B was a little stronger, all the way up to almost 90% in children and almost 80% in adults. But overall, if you compile all that data, children are about 50% less likely to have an emergency department visit and 70% less likely to be hospitalized. There are options for antiviral treatment still for influenza. Typically, the sooner the better. And that's seen as the best clinical benefit when it's given early. You may have heard of some of these. I put the common name on the far right. This is off of a CDC and ASCP chart. Over here on the far right, I put the common name just so you might recognize it. So Tamiflu, Rolenza, Rapivab, and Xofluza, which is relatively brand new. And you can see that all of these can be given for different years. And the first one's any age, and then they kind of vary. Some are oral, some are inhaled, some are IV. It kind of depends on your primary care physician or other doctor as to what they're going to use. So what about this upcoming year for vaccines? We already showed you what was circulating on those slides earlier. So I made some points here. Again, this is the European recommendations. are basically identical to the United States right now. And so we're looking at, in purple you can see here, a trivalent in the US. They're formulated primarily against these three viruses, the H1N1, again, that's the swine variety, H3N2, which is a swine variety, and then this B Victoria virus. And you'll note at the arrow here, that's because we had a quadrivalent last year. We dropped it to trivalent because we have not seen this Yamagata B strain circulate since March 2020. So right now we are leaving these at these three primary circulating that we're predicting for the upcoming season. Are we going to be right? Or is CDC and others going to be right? It's always something to watch. We have had seasons where something surprised us, and then that's when you see less effectiveness of the vaccine. You really want to discuss your different flu vaccines with your healthcare practitioner. It kind of depends on your age. You know, are you pregnant? Should you use a nasal flu vaccine versus a intravenous shot? So it just kind of depends. So you always want to talk with your physicians about these options. Certainly one of the things I like to tell my family and friends is that really in the US, in the United States, you typically want to get vaccinated towards late September and October. It takes about 2 weeks to build antibody for protection. And really flu typically doesn't really get rolling until mid-October. And so if you do it in October, you're going to have better protection maybe all the way through February, March, maybe even into April. If you do it in July or August or even early September, that antibody titer is going to wane and drop some. And so you may not be as protected at the end of the season. So that's kind of the typical recommendation. Testing and diagnostics, just threw a chart here. This is from the CDC again, and I'm not going to read this to you, but you can see that we have RIDT test, rapid influenza diagnostic tests that pick up both. These are rapid, less than 15 minutes. We have rapid molecular assays that are also pretty quick. All of these pick up A and B, by the way. We have IFA or direct FA. I did a ton of these when I worked for the health department. These are your immunofluorescent direct antibody test. It's using a fluorescent microscope. They're picking up antigens on these cells that have been infected. This is a little longer, as you can see, up to 4 hours perhaps. There is RT, reverse transcriptase PCR, both single and multiplex, real-time and other types of RNA-based tests. These are kind of depends. Some are pretty rapid, some can take longer. You can multiplex these, so you might be looking for a variety of respiratory agents, so that's kind of nice. I can't express how important it is to have strong quality control and validation of each and every one of these types of tests in the medical laboratory. Again, you want a qualified, credentialed medical laboratory professional running these types of tests, which are not CLIA waived. You notice up here, the top two are CLIA waived. These can sometimes be done at home. You might be doing these in clinics where other professionals like a nurse or perhaps someone else is running the test. These are like pregnancy tests. You can look at them yourself over the counter. They're pretty good, but you can have issues of some sensitivity and specificity problems there. The cell culture and the tissue cell culture, I did this in my public health days. Loved working in the virus isolation lab, but you don't see that type of test in hospitals. It takes too long. It can take days, but they work really well. So flu testing and diagnosis, the IDS, the Infectious Disease Society of America, recommends the use of rapid influenza molecular assays over diagnostic tests, those rapid ones, when you're looking at outpatients, respiratory specimens in outpatients. They recommend the use of RT-PCR or other types of molecular assays when you are in the hospital. So there's reasons for that, because you can have a higher rate of false positives or false negatives if you're using the wrong type of test in those populations. So again, quality control, validation is really critical. These are things that make medical laboratorians and scientists try to talk to the public about why this is so important, because everything matters. I always tell my students and my friends and family, it's really all about timing, right? So you can have the greatest test in the world, but if your specimens are not collected at the right time or when shedding is highest, it could be a false negative, right? So that's a problem. Each test also has its own specifications for specimen collection. Some are nasopharyngeal, some are nasal, some are throat swabs, some are aspirates. You have to follow those recommendations. Some types of flu tests are better able to detect A over B, so you want to know that. And even the flu activity, false negatives are more likely. Oops, let me back up there. False negatives are more likely when flu activity is high, but they can occur anytime. And similarly, false positives are more common when flu activity is low. Here's a couple of specific references if you're interested that goes into some great information about comparing these different tests and what's really important. Again, if you're doing your testing in a medical laboratory or having it sent somewhere where there's credentialed professionals, this type of work is always being done. Rapid test is not as closely followed because they're CLIA weighted. So the importance I put over here in red, the importance of validation for laboratories prior to the respiratory season and the benefits of molecular testing cannot be overstated. It's really the state of the art. They're the most accurate. There may be times when rapid antigen tests are useful just as a screen, but we really want to understand this issue between false negative and false positive, right? I always tell my students false negatives are worse because that means you actually have the flu and you're not treating it, or you may not be telling that person to stay at home. False positives, while not good, you at least are treating someone even if they're not positive. So in my kind of world, I think the negative is the worst. The false negative problematic. And I'll go to my grave saying that it's really critical for a medical laboratory professional to conduct and interpret all medical laboratory testing. Our profession is trained, credentialed. We put in, massive degree work and on the job clinical training around testing. Everything we do is about testing, not your physician, not your nursing. They're all important. But when it comes to testing, you really want that to be run by a credentialed professional. So flu is constantly changing. Keep an eye on the watch here. And that's referred to drift. They can also do these shifts that I talked about. That's why we constantly administer vaccines and we update those. And we want to really watch treatment based on resistance out there. So viruses change. That means the vaccines need to be updated. Treatment may be changing. And we really want to support flu surveillance to monitor them. The other issue, again, is animal reservoirs. They allow this kind of stealth mode. So these can hide in swine and birds and things like that, pigs, and so forth. So upcoming, what can we expect? Well, we know this is just an overall pneumonia, influenza, COVID-19 mortality over these different seasons. Again, you see kind of the effect here from different angles. You've got deaths, you've got kind of baselines. And this is just to remind everybody that flu is very unpredictable and it's hard to predict. However, we can state that it remains unpredictable. And we know from the past seasons and many seasons that flu can circulate early. It can result in higher rates of illness and mortality in children. And they often are co-circulating with other viruses. And so annual vaccination as well as other vaccines is really the most effective way to prevent influenza and other illnesses. So for instance, my parents who are in their 70s, they're also getting pneumovax to protect against bacterial pneumonia. There's the new RSV vaccine that we're going to talk about in a minute. So all of these can be preventative and helpful as you go into the flu season. And then lastly, just a reminder, this is happening in the US right now. If you're curious, right now we have had 8 H5N1 bird flu in humans as of July 16th of 2024. We've had 9 overall, but that goes back to 2022. 8 have been in this past year. We also picked up this year a highly pathogenic avian influenza called H1N2 in 2024 in a human being. So only 1 of those so far, but this is the importance of surveillance and watching these types of agents in nature and as they move into human populations so we can be more protective of that. Okay, let's jump into RSV while we have some time here. RSV is pronounced respiratory syncytial virus. It's a common respiratory virus. It's kind of like a mild cold most of the time. Most people recover, but it can be serious for infants and older adults. And it's pretty common cause of bronchiolitis. So messing with those small airways in your lung, and pneumonia, which can be more serious in children younger than 1 age when you're looking at the US. It is very common. It's the 4th most common viral pathogen after flu and SARS right now. There's 2 subtypes, A and B, based on how you type it. And it's primarily a respiratory droplet or direct contact surface type of spread. You can be contagious for up to a week or so, but you can continue to shed this if you're immunocompromised. And unfortunately, an infection doesn't always confer long-term immunity. So you can see recurrent infections happen. That's never fun. Anyone can get it, but typically later in life or less severe later in life. Premature infants, young children, especially those that have issues like congenital problems, immunocompromised immune systems, or adults, and then older adults, especially with respiratory issues and cardiovascular issues. Those are the primary risk populations for RSV. It unfortunately can survive for many, many hours on hard surfaces like tables and cribs. It can also stay and hang around in tissues and softer surfaces. And so we really want to watch for that. And it's pretty much throughout the year, although we do see this circulating in the winter with the US more often. So this is kind of the snapshot of RSV. Again, a lot of outpatient visits in younger children, 58,000 hospitalization in young children, about pushing 200,000 hospitalizations in those over 65, and up to 14,000 deaths as you get into those older ages. I also wanted to mention one of the headaches with RSV because it can get into the lower respiratory area. There is often a bacterial kind of superinfection that can occur. So bacterial pneumonia, you can see in one of these studies that I pulled up about, out of about 771 subjects, 12.5% of these had RSV infections. And you can see 18% of these, as you broke them out, had a confirmed bacterial infection. So they need antibiotics as well. So that's important to know. But you don't want to give antibiotics to those who do not have bacterial infections. So that's why diagnostic testing and validation can be so critical here. Again, here's some of the testing formats. Real-time RT-PCR is the most sensitive for RSV. Antigen testing is good in children, less so in adults. Culture, again, and serology are really more public health and research. We really don't do that. We really want to focus on tests that sometimes might be able to differentiate those subtypes, but we're not real sure if that's important for RSV. Again, just showing you, just to move along for time here, there are studies out there that have shown older adults can see severe lower respiratory complications, LRIs, lower respiratory infections. They have respiratory failure, prolonged hospital, higher mortality, much like flu. So it's really important, again, to figure this out in older patients or really young immunocompromised patients. Look at this chart comparing how RSV can actually be a longer stay, almost double the stay of hospital length. Ventilation, perhaps, and even costs can be higher than influenza. So it's important to diagnostically test and differentiate between flu and RSV and ultimately even COVID, because these things can help with treatment and planning for healthcare plans with individuals that have risk factors. The nice thing that happened in 2023, many of you know, we have a new tool, nirsevimab, which is a monoclonal. It's approved by the FDA. It protects infants and young children. This is wonderful, up to 80% reduced risk. And 2 different vaccines. They're recombinant protein vaccines, both approved in adults ages 60 and older, also about 80%. And so the CDC right now is recommending the following. If you're 60 and older, a single dose in late summer or early fall of one of these 2 RSV vaccines licensed in the US by GSK and Pfizer, 2 different. If you're pregnant, 1 dose between weeks 32 and 36. Again, this is a transplacental protection. And then infants and young children, there's options for these different monoclonal antibodies that I mentioned, the brand new one and one that's been around for a while in really young populations can really help protect that age group. So, not to read this to you, but the recommendations really for the public is that you should be talking with your primary care physician, especially expectant parents. If you are an older adult, 60 or older, you really should be considering RSV vaccination now. And then again, like anything, if you're sick or you know people are sick, stay away from them, especially if you're in those risk categories, because that's going to help prevent you from getting this perhaps. Okay, now we're here at our old friend. Most people are tired of talking about coronaviruses, but they still are important to discuss. Just a quick reminder on some of this. I don't have quite as many slides here, but in some important updates, there are 4 normal, if you didn't know this, coronaviruses. There's actually quite a few. There's not going to be a test after this, but you can see if you're a virologist, you can see some of the families and subfamilies and genus here. And as you break this down in the coronavirus family, there's 4 kind of normal that are mostly responsible for common colds. And then these 3 novel in the red are the ones that we've, been more concerned with. Again, not to read this to you, but the highlights of this slide is that most normal human coronaviruses can cause up to about 10% of common colds. We also deal with rhinoviruses and adenoviruses and other types of cold viruses, but coronas can do about 10%. And these are primarily going to attach, these viruses will attach in the upper airway. So I want to make this kind of important differentiation. These are the normal coronaviruses. They stay up high, less dangerous. And then look at these others. So when you're talking about SARS, the original SARS, Middle Eastern respiratory SARS, or the brand new SARS-CoV-2, which is causing COVID-19, these have ACE2 receptors. That's their primary entry site, and those are found all over your body, but especially in your lower respiratory tract. And so that's why we worry about these, because it causes a more dangerous type of infection with more pathology in the lungs and alveoli. You can see some of the case mortality rate here. Original SARS was about 10%, but it soars in older age up to 50%. MERS, which is still not contained, the Middle East, exposure to camels and healthcare workers, almost a 35% case fatality rate. And then SARS-CoV-2, which started in 2019, early or late 2019, it's not contained. It's variable. The case fatality rate is probably somewhere in the 1 to 5% range, thankfully. It was just such a massive new introduction of a novel virus is why we saw so many deaths. Thankfully, that wasn't like in the 30 to 40% fatality rate, or things would have been really, really bad with respect to mortality. The other thing, just to back up, when you're a physician or a laboratorian, you got all of these other agents to deal with. So again, coming back to testing, so critical to have a good target, a molecular target or an antigenic target that's been validated and QC'd, constantly looking at that, because you have so many other agents that are in circulation, bacterial, fungal, viral, sometimes even helminthic, that can cause different things. So we want to know that our testing is working and it's well validated. One of the big things that we know about SARS-CoV-2 is that ultimately we know now that it's aerosol transmitted. That's why it's so easy to get it throughout a full room, versus respiratory droplets will fall quicker because they're wet. And so that's kind of the reasoning early on between 6-foot separation. We really know that that's not enough, because aerosolization means these things are floating in the air and they can move throughout a room. Now we know how important it is to watch our air handling, the turnover of air, truly physically distancing, maybe staying away from people that are symptomatic, because we know how easily this virus is transmitted. By the way, right now in the US, SARS-CoV-2 is kind of showing an uptick. You see that it dropped. This is the 2023-24 season. This gets us to about mid-June. Right now, I'll show you some current data. July and August, we're seeing an uptick. So more than half the US states are seeing higher positivity right now of COVID-19. So here's the current snapshot. This is through July 6th. This is a CDC tracker. You can grab this off their COVID tracker if you're interested. You can see we're about 11% positivity rate right now in the U.S. The previous week was 9, so we're rising a little bit. About 1.3% showing up in emergency departments, about 2% hospitalized, and about 0.8% with deaths. So deaths, thankfully, are still low, but it still is happening. There is mortality from COVID-19. We know that unvaccinated people are at a much greater risk of dying from COVID-19. One of the key points I try to make with my friends in public and others is that no vaccine is 100% effective. So it always drives me crazy when people kind of bring up, well, the COVID vaccines don't ultimately protect you. No vaccine ultimately protects you 100% of the time. Think of vaccination as a risk reduction measure. It's just as important to stay away from sick people. It's just as important to have good, clean air in rooms, to wash your hands, to physically distance, to be careful when you travel and you're around people you don't know, and to be vaccinated. All of those are important so that you don't raise the risk of mortality or morbidity, especially in immunocompromised people. Remember, it's not just about you, it's about the people around you. You want to protect others that may be at higher risk. Now, this is a crazy busy slide, but I did want to show it to you because this is kind of my world of looking at genetic strains and variants. Again, I'm not going to jump all over this, but I just want to show you that this is in the last, from March till about June 20 of 2024. This is what surveillance is important for. Public health, research, and others that are following viruses that are changing. Look at the change right here. This JN1 is the most current variety. This comes out of the Omicron family. And so this is why the vaccines are going to be changing for September for COVID, is that we want to follow these. And again, you can kind of see the lineage here. It comes out of Omicron, and we got a lot of JN1. We're also seeing some other versions right now. This terminology too, if you're interested, they're different strains and variants. A variant is when a virus changes or mutates from the original version. Okay, so a variant is like a new take on an original virus. A strain is when you have a collection. It's when a virus has so many variants that it starts acting differently. Remember when Omicron became crazy transmissible and we noticed that? So that's kind of a strain. And then variants can come out of that. And so you're seeing JN1 or these other KP2s and so forth that come out of that original Omicron strain. Just a little quick lesson in virology there. And this also is kind of interesting to look at, going all the way back here to the beginning. Remember, we had our Wuhan index strain. Then we went through alpha, beta, and gamma, delta. You might remember this huge epidemiological spike during January of 2021. This was the Omicron wave. Fortunately, there wasn't a ton of mortality, but there was a little pickup in mortality. And then we kind of sunk down into these new Omicron variants like JN1 and FLIRT. These are what are circulating right now. It's why the vaccines are going to be a little different coming in September. And I would encourage you to seek vaccination, especially if you're in risk groups, but really everyone should be seeking vaccine. And again, not a test question, but again, this is just kind of interesting looking at the origin strain and how we track this for genetic testing. Again, this isn't important that you look at all this. This is kind of how it's unfolded. Wuhan, alpha, beta, gamma, epsilon, kappa, lambda, eta, mu, iota, zeta, delta, Omicron. And now we're currently in these Omicron variants. The JN1 and FLIRT variants are where we are right now in looking at this evolving virus. There are still diagnostic tests available. Thankfully, we have lots of nucleic acid tests. We have rapid antigen tests. Again, there's some information about this regarding which one's best. The rapid tests are more of a screen. They're good for kind of seeing what's happening at home, maybe point of care. They're not as sensitive as nucleic acid amplification tests, which are called NAT tests. Those are the most sensitive and specific to kind of follow patients and knowing what variants are out there. We do have antivirals. I actually did an article on monoclonal antivirals back in early 2019 and 2020 when they first were talked about. The public suddenly was talking about monoclonal antibodies more than ever. Unfortunately, some of these are not really active anymore. Again, in the background, you can see some of these are more targeted at spikes, some are more protease, some are elsewhere, replication types of proteins. And so these are the types of targets that pharmaceutical companies are working on. Right now, Paxlovid is still effective. It's probably the best effective as you get it as soon as possible after symptoms. So staying up to date is important. As of June 27, 2024, they adopted the ACIP recommendations for use of a 2024-25 COVID vaccine in people 6 months and older. It's expected to be available in early fall of 24. And all of this is just kind of a compilation of that statement. Really, everyone should be seeking this unless you have a reason not to be vaccinated. It's going to be important to seek that new vaccine. And kind of as we wrap up, this is what the public doesn't always see. I mean, these overlapping seasonality of respiratory viruses is crazy, right? We've got RSV, we've got coronavirus, we've got others that we haven't talked about, like enteroviruses, adenoviruses, parainfluenza 1, 2, 3, and 4. Those are croup. You see those in children. We got flu throughout the year. So this is why it's so critically important to have good, strong quality control, especially in our molecular testing platforms, but really in all testing platforms, including antigenic-based testing. We have those CLIA wave testing types of rapid testings at home. Those are important, again, I think, for screens and understanding what might be circulating, helping people to make decisions, maybe if they can't get to the doctor. But ultimately, the best type of test is going to be conducted by a medical laboratory professional from the orders of your physician, and you're going to know what you have and when you have it. Really important. I'll finish up with this. In my 3 decades of working in public health and medical laboratory situations, this is just our world. And I always tell people that everything I or we do before a pandemic can seem alarmist. We're always worried because we're watching what's out there. But then if we don't do anything, everything will seem inadequate. And I think that's what we have really felt in the past 5 years. The public has been, sometimes frustrated with things, but we're doing the best we can with the best information we have. And sometimes it's novel. We're learning as we go. And so that's really critical for the transparency of public health and for people to understand we are doing the best we can with the information we have at the time. A bunch of references for you. Again, feel free to follow up with me. You can follow me online. You can reach out to me. I'm on various platforms, and I'd be happy to answer any questions now as we finish up the webinar. Thank you so much again.
Thank you so much, Rodney, for that fascinating presentation. We really do appreciate you sharing your expertise with us, as well as providing such a comprehensive overview of the upcoming respiratory landscape. And thank you to everyone in the audience for your active participation. We will now move on to the Q&A session, where you have the opportunity to ask your questions. To submit your question to Rodney, please use the chat box and type your question and click send, and we will do our best to answer as many questions as time allows. I can see that we've already received several questions, so I will begin by addressing them now. So Rodney, your first question is, should you have a COVID-19 PCR test if you have been recently positive?
Yeah, this is a great question, George. One that I do a lot of education with family, friends, and colleagues and others that ask this question. This is really important because we know that you can have asymptomatic patients, you can have other patients that are coming off of being positive or being symptomatic. And so after you have a positive test result, one of the things to remember is that you may continue to test positive for some time. And some tests, especially those really powerful PCR tests that everybody has heard about, the polymerase chain reaction types of tests, they can show a positive result for up to 90 days, almost 3 months. That's because, George, the virus can have limited pieces of RNA. It kind of falls apart in your body, and so you can still amplify that. You're actually not in a positive patient, but you can show it's almost a false positive issue. And so the problem with that is if you're showing positivity, Reinfections could also occur within 3 months. So this gets complicated. And so it can make it really hard to know if a positive test indicates a new infection. And so it kind of goes back to understanding the testing modality, working with your physician, and really the physician working with a laboratory to maybe understand what's best for a test. It might be important to just do antigenic testing for about 3 months to kind of know what's happening, because that's going to be more likely to show you a negative versus a positive.
Thank you so much for your incredibly detailed answer there, Rodney. I am aware of the time, so we perhaps have time for just a few more questions before we close out the session. So moving on, your next question is, why does influenza virus have so many different virus types?
Yeah, this is a common question. We kind of touched on it a little bit in the talk. It's all about those segmented genomes and how many pieces that RNA genome they have. So influenza is known for their rapid evolution and variability because of those segmented nature of the genome. The genome is the RNA nature. It's made up of 8 separate RNA strands, and they can recombine those H and N pieces. And so what happens, if you can imagine, when one cell is infected with more than one flu virus, this can happen. The genomes can shuffle together. This is what we call recombination. They recombine. It's a mixing, a gene mixing, and that results in new strains that perhaps we've never seen before. And so that's where this happens. And for example, a cell can be infected with viruses even from different species. So a swine strain, a bird strain, maybe a human variety, and they'll mix. And this is why we start seeing H1N1 or H3N2 or H5N1, is because those segments get recombined. We often think that primarily happens in swine. The pig is often called the mixing vessel, but it can occur in other reservoirs. So that's the headache with influenza, especially A strains. They love to mix around and make our immune system confused and frustrated as we kind of go through this process with an influenza infection.
Excellent. Thank you again, Rodney. That's another fantastic answer. And our final question that we have for today from our audience is RSV a zoonotic virus?
Yeah, so the good thing about RSV versus SARS and flu is that RSV is not a zoonotic agent. So RSV is primarily a human-based virus. It can show up in cattle occasionally, but it's a low risk to transmit back and forth in other types of animals. So it doesn't spread easily in that way. And so if you now can get people vaccinated and treated and kind of separated during infection, you can really help control infection versus flu and SARS and other types of zoonotic agents that can go hide out in animal populations. Sometimes they can even hide in plants, other types of viruses. So it's nice when you can kind of keep that from happening. So it is not a zoonotic agent.
Excellent. Thank you so much, Rodney, for answering all those questions. But unfortunately, that is all that we have time for today. And that just leaves me to say once again, thank you so much, Rodney, for your time today. We really do appreciate you being with us today to present. And to everyone in the audience, thank you once again. Goodbye.
Thanks, everybody.